My name's Trey Bateman. I am, as Dr. Bazzoki said, I'm an assistant professor in neurology and psychiatry at Wake Forest, and I'm a staff behavioral neurologist at the Salisbury Veterans Affairs Medical Center. My goal today is to just talk about the medical approach to behavioral symptoms and dementia and try to give you some insight into how I approach these problems when patients come in to see me in clinic, to give a medical framework for then going through what's really important facets that Pat and Helen and Lisa are all going to talk about in the upcoming presentations. First, just for anybody who knew Dan, so Dan was my mentor for a decade, and he was my friend for just about as long. This is me and him at the American Academy of Neurology in 2017 when I was a senior resident at UNC. So I owe my career and approach to taking care of patients to learning from Dan. So I'm forever indebted to him. So disclaimer, I am a federal employee at the VA, just for everybody to know that these are all my opinions. They do not represent the views of the Veterans Health Administration, the DoD, or the US government. The overview of what we're going to talk about is I'm going to try to give you some common language. Some of this may be review for folks. Some of this may be putting terms that you think you know in a different light. But I want to make sure that we're all on the same page with the language we're using. I'm going to talk about how different dementia syndromes may present with different symptoms. Talk about how meds, before we talk about what we use to treat these symptoms, I'm going to talk about how medications can actually be part of the problem, and how I approach looking at a medication list to look at things to maybe stop rather than start. Talk about what we can treat and when to seek our help, and then a few words about trying to work effectively as part of a team with your physician that's helping to manage these problems. First, the words that we use for cognitive decline, they get thrown around a lot, and I think it's important that we all sort of have a good framework for what these words mean. And so when you're thinking about cognitive disorders and decline over time, the first thing to note is that there are just normal changes of aging. And I see plenty of folks that come in worried about cognitive decline, and it may in fact just be normal changes that everyone experiences to some degree with aging. We have changes in our skin, our hair, our muscles, and our brain. And so we do see some expected changes. When we use the term mild cognitive impairment, what we are saying is that someone has a concern, either the person experiencing the impairment or a caregiver, a loved one, or an informant has some concerns about changes in cognition. And then when we measure their memory or visual spatial cognition or executive functions, we see that those test scores are low. But importantly, there's no major problems in day-to-day activities. People are still going about their day-to-day activities without much difficulty. Now, MCI can have a couple of different outcomes. Some people seem to just get better, and we don't necessarily have a great cause for why the MCI happened. It's really just a description of what they're experiencing. Some people have a stable course. They sort of stay at MCI, and they don't really get better, but they don't get worse. And then in some significant subset of people, MCI can be thought of as a pre-dementia stage. Dementia, one of the most common questions I get in clinic is, well, what's the difference between Alzheimer's disease and dementia? So dementia is it's a description of what someone's experiencing. It doesn't tell you what's causing it. There's lots of causes of dementia, of which Alzheimer's is one and the most common. But what dementia really means is that there are changes in memory and thinking. There are low scores on a test, on tests, and it's causing difficulties in day-to-day life, day-to-day activities. When we think about the severity of dementia, There's, when we say mild severity, what we mean is that there's trouble in these things called instrumental activities of daily living, and those are things that are required for independent living: driving, cooking, cleaning, finances. When dementia progresses to the point that it impairs basic activities of daily living, which are things that are required for physical needs, things like feeding oneself, dressing oneself, or performing one's own personal hygiene. When those are impaired, that's moderate dementia. And then severe dementia is really when the impairment is such that someone is fully dependent for another on all of their daily activities. This talk is going to be focused on behavior and behavioral symptoms. So behavior is just what we can observe and measure that others do, good and bad. We're focusing on challenging behaviors in particular, and these are things that are causing people from successfully participating in their daily life or successfully living in their environment, be it the home, the community, or a residential care facility. Behaviors, and this is a really important point that both Pat and Helen are going to come back to, about behaviors serve a purpose and communicate a need in some instances. And if we don't take a step back and try to understand what might be driving those behaviors, then we may be missing a real key component of what's driving that behavior in someone with dementia, because they may be less able to be able to tell us what that need is. Other terms that you'll hear, I'm going to use behavioral symptoms because I think those are straightforward and easy to understand, but if you look online for these things, you'll see these other terms used: behavioral and psychological symptoms of dementia and neuropsychiatric symptoms. And those really all refer, for the purposes of my talk today, to the same thing. So this next slide is just all of the neuropsychiatric symptoms or behavioral symptoms that I'm going to go through to give you a sense for what I mean when I say behavioral symptoms in dementia. And I'm going to go through each of these in little clusters that they sort of go together and describe what I'm talking about. So the first three are types of emotional dysregulation. So depression, and that's really referring to a down, depressed, hopeless feeling that someone has, and it's persistent. It's not just feeling down for a couple of hours every few days. It's really a persistent decline and decreased mood. Anxiety, again, is a feeling. These are emotions. So these are things that people are feeling. And this is when someone feels excessively tense, has excessive nervousness or worry. And then elation is if somebody appears to feel almost too good. They may behave in sort of a childish way, or make big claims, or act too happy. And those can all be problems depending on the severity of them. Apathy is a symptom that goes along with depression sometimes, but not all the time. And apathy really just refers to a decrease in interest or decrease in motivation. So people are less likely to engage in their usual activities, less spontaneous. This is something that frequently I find people who are describing this to me almost always think that their loved one is depressed. And they may be, but they may not be depressed. It may just be isolated apathy. And that can be important for me to try to tease out because it affects the medications that I may choose to use. These next three are types of impulse control problems. So agitation or aggression refers to agitation can sometimes just refer to excessive motor activity. So people are, people are moving around a lot. It overlaps with motor behaviors, as you'll see. Whether you call pacing a motor behavior or a sign of agitation can be a little bit of a judgment call. And then aggression is really if people are verbally or physically aggressive. This often happens in the performance of personal care activities. People may be resistant to receiving the care that we all know they need, such as help with bathing or cleaning someone up after they've had an episode of incontinence, but that doesn't mean that they are able to necessarily understand that. And so you may have resistance to that care. Irritability is probably the most common thing I see early on. People will say that they're just cranky. They're not like they used to be. Their temper's a lot worse. They seem to, they have a hair trigger for their temper, and that never used to be the case. Motor behaviors. First, anything that someone does in a repetitive fashion, handling buttons, wrapping string, just sort of purposeless motor activity. Pacing can fall within this category. Disinhibition is when people don't sort of inhibit these things that we would normally think that they would. So they may behave excessively familiar with strangers, make insensitive or hurtful remarks, or talk about things with strangers that they may never would have talked about in the past. Delusions and hallucinations make up what we refer to as psychosis in dementia. And delusions are when someone has a fixed false belief. You cannot talk someone out of a delusion. These are absolutely fixed, and nothing you say is going to change the belief in that. Delusions of stealing or delusions of abandonment or infidelity are not uncommon. People may misidentify someone, so they'll see their wife and they'll go, well, that looks like my wife, but that's not my wife. That's an imposter who just looks like her. Hallucinations are when someone perceives a thing that is not there. So visual, auditory, so they could see things that are not there, hear things that are not there, even feel or smell things that are not there. And it can range from simple things such as shadows out of the corner of someone's eye to very complex hallucinations, seeing children, animals, and the like. And there's a spectrum for how much people recognize that these are real or not. Some people are able to tell you in the office, yeah, I know they're not real. I see the dog there and it doesn't bother me. Other people are convinced both in the moment and in the office that these are absolutely real things. And to that person, to the one experiencing that, they are real. It's like telling someone that they're not seeing something directly in front of them. Nighttime behaviors. This refers to things like sleeping too much, sleeping too little, acting out dreams, and then changes in appetite and eating. Again, kind of eating too much, too little, or a change in food preferences. So putting them all back up there just as a broad overview of the types of symptoms that I'm routinely evaluating for in clinic. These symptoms overlap, right? So determining whether something is anxiety or agitation, apathy or depression can be difficult. And sometimes it may direct your treatment a little bit, which medications you may choose to use, the underlying cause of them. And that's the job of the dementia specialist or the doctor that you're seeing. What helps me is you as the caregiver, you're the expert in knowing your loved one's behavior. You can give me such a wonderful view into what's going on that helps me try to figure out what that symptom is really indicative of. And so getting a good description is very helpful to me. I try to measure these symptoms by standardized questionnaires. And the reason for that is both to make sure that I'm doing a good thorough assessment of all of the different symptoms, but also it allows me to track things over time. The gold standard for assessment is really just a fancy version of saying, how is someone doing, and trying to quantify that. This is likely the most common measure that's used. It's a little bit of a busy slide, but I'm going to walk you through it in a few pieces to describe why I use this and what it's trying to get at. This is the Neuropsychiatric Inventory Questionnaire, and it asks about all of those symptoms that I just walked through. And you can see on here that I've just got one question about delusions up, but this is iterated throughout all of those behavioral symptoms. And this was developed in part by Dan Kaufer when he was a fellow and young attending, working with Jeff Cummings, who is the originator of the Neuropsychiatric Inventory. Dan helped to develop the questionnaire version, and in particular, Dan was instrumental in the distress scale that we're going to talk about here. And I think that really, it gives you an insight into what Dan was thinking about even back in the 90s when he was a young attending, and the passion that he had for identifying and helping families. The first question is the symptom present, yes or no? And so delusions, it gives you a nice description of what delusions are, and you say yes or no. And if yes, how bad is it? And the severity of the symptom is just that it's either a big change or it's not a big change from someone's normal behavior. And that's distinct from the distress. So you could imagine somebody who has a very marked change, but the symptom itself may not be distressing, because the distress scale really gets at how do you feel about this symptom. The reason that's so important is that behavioral symptoms, more than cognitive symptoms, are really a strong predictor of distress for caregivers. 61% of symptoms that are reported are in the moderate to severely distressing category. And then it's really that, more than the presence of a symptom, that predicts future placement outside of the home. So when distressing symptoms are present, that really lets me know that those are things we need to key in on and do our best to try to treat and improve. I'm going to just walk through a couple of different, more common forms of dementia. Alzheimer's and vascular disease I'm putting together because they're so common and they're comorbid and they happen in the same person not infrequently. And their behavioral profiles are relatively similar. Of course, every person is unique and different, but if you look across a population, these are largely similar. Majority of patients will experience a significant symptom. In the early stages, it tends to be depression, anxiety, apathy, irritability, and agitation. But as the disease progresses to more moderate and severe stages, that's when you start to see psychosis, big sleep and appetite changes. And often here, the appetite changes that I see are a reduction in the amount of food that people eat. And then agitation and aggression can become more common in the moderate to severe stages. Lewy body dementias are the second most common neurodegenerative cause of dementia. So vascular disease is technically behind Alzheimer's disease, but vascular dementia is not a neurodegenerative disease. Lewy body dementias are. The terminology here is pretty confusing, and so I'm going to try to just easily walk through the words that we use for Lewy body dementia. So the first is Lewy body disease, and that just refers to a brain disease that has these pathologic features called Lewy bodies. And that practically refers to Parkinson's disease and Lewy body dementia. But what gets confusing is that Lewy body dementia is really these two other separate disorders. And you'll hear people use the terminology in an imprecise way, but I think it's relevant to know that there's a lot of overlap between Parkinson's disease with dementia and this other entity called dementia with Lewy bodies. And what it really boils down to is, when did the cognitive changes occur relative to motor changes of Parkinsonism, the slowness and stiffness? If somebody has well-established Parkinson's disease, and we use sort of arbitrarily a 1-year rule, if you've had Parkinson's disease for a year and then you develop cognitive impairment, that's Parkinson's disease dementia. But in cases where the dementia develops along with, or in some cases quite prior to the Parkinsonism, That's what we refer to as dementia with Lewy bodies. And both of those are within that category of Lewy body dementia. The behavioral presentations here are very common, and in fact, they're part of the core criteria with hallucinations. And so early psychosis is much more common here versus Alzheimer's disease, where psychosis occurs, but it's usually years into the disease process. It's not uncommon for people to come into my clinic where psychosis is really the predominant symptom presentation. You'll hear from Pat about her experiences as a caregiver for somebody with Lewy body dementia, and if you've read her book, Dan's one of those doctors, but I think she saw 12 different doctors before she got a diagnosis and a treatment plan. That's unfortunately common with Lewy body dementias. It on average takes about 18 months and 3 different doctors to get a diagnosis. The next class that I'm going to talk about are frontotemporal dementia. Again, here there's some different variants. There are 2 language variants. Each of those are early prominent changes in language and generally less behavioral symptoms early on. There's also a behavioral variant, which you'll probably not be surprised to learn has a lot more early behavioral impairment. And in fact, those behavioral symptoms are core in the diagnosis. And so apathy is a very common thing that you see here. Over 75% of patients with behavioral variant FTD have apathy. There's also appetite changes, but here it becomes important to really ask, well, okay, there's appetite changes, but what kind of appetite changes? Because here it's not a reduction in eating like you may see in more progressive Alzheimer's disease. It's a change in preference, often carbohydrate or sweets craving, to a degree that's quite out of the ordinary. Other behaviors, ritualistic behaviors, can be very impulsive, very socially inappropriate, and those are core features of the behavioral variant of frontotemporal dementia. Psychosis here is rare. It can happen in some, it's a little more common in some genetic variants, but it happens, but it's much more rare than in dementia with Lewy bodies, where it's more common and in fact a core criteria. The first question that I'm asking myself is the behaviors that are there, do we need to treat them? And that, you don't have to treat every behavior. And so I'm asking myself, are the behaviors harmful to either the person having them or the people around the person having those behaviors? How frequent are they? Can somebody be easily redirected away from that behavior? And does it contribute to distress? If they're not harmful, infrequent, easily redirected, and not distressing, there may be no reason to try to treat that behavior. And then I'm also trying to ask myself, is this something for which medications will be effective? So if we take, and just an example of that, if we take verbal aggression, you can sort of divide causes into things that are more likely to respond to medicine or less likely to respond to medicine. So if someone's in pain, if they have psychosis or depression, and that's what's driving the aggression, I can treat that. I know what to do for that with medications. But there's a whole host of other reasons that somebody may be verbally aggressive. They may have unmet care needs in a residential facility. They may be bored, or they may be overstimulated. Those are things that I can't treat with a medication. And if I jump straight to a medication, I'm missing an opportunity to really improve someone's quality of life and reduce their behavior by addressing some of these things with a non-pharmacologic approach. The first thing that I always do once I've identified that a behavior is present and significant is how much is safety an issue? Some things have to be treated more aggressively, more promptly. We don't have time to wait for a medicine that's going to take 4 to 8 weeks to help, because safety is at stake. Somebody is verbally and physically aggressive, and if we can't help get that under control, the individual living with dementia may not be able to stay in their home. And so that can be something that requires much more prompt attention to treatment. If there's been especially if there's been a change in behavior, it's really important to consider, is there something else going on? Before I jump straight to treating, is there a physical cause to those symptoms? And that's where I'm looking for things that could be causing a delirium. So infection, pain, sleep problems, all of that could trigger a delirium and a change in behavior. And then finally, medications are really important. When we talk about reversible causes or contributors to cognitive impairment, we often talk about, lab values that we get, vitamin B12, thyroid hormone, but really medications are the most commonly encountered reversible contributor to cognitive impairment. And so a medication review is absolutely essential. The first class I'm going to talk about, because they're so common and they're over the counter, are anticholinergic medications. And I'm going to describe what that means and why it's a problem. There's a lot of drugs here. And so this is I don't expect anybody to read this. I've got it blown up in a slide where we'll go through a couple of drugs, but this is a really nice pocket card from Elder Consult, which lists a bunch of different classes of medicines along with specific medicines that have anticholinergic properties. Sometimes the benefits of using these outweigh the harms, but I always have to consider that. So this is the only picture of a brain that I have in 44 slides, and that's saying something for a neurologist. So this is a cartoon description of the cholinergic system. So these little blue dots here are small areas in the brain that produce a chemical called acetylcholine. The only thing to really pay attention to here is how widely they project. This chemical is working everywhere in the cortex of the brain. And so if you give someone a medication that interferes with that, it's not hard. It's not a real leap to understand how that sort of messes up the brain's processing and can lead to confusion, especially if somebody has vulnerability in their brain because of dementia. So a couple of very specific medicines to go over. The first bit here, so these are antihistamines and cold medications. The number one problem here is Benadryl. Anything with PM behind it, NyQuil, is anything with diphenhydramine in it, it can be a problem in older adults, even without dementia, but especially with dementia. And so Benadryl is probably the biggest contributor. Bladder problems, very common as adults get older, and oxybutynin or ditropan, telteridine or Detrol, both common medications used for urinary incontinence, but yet also are anticholinergic and can cause some confusion and worsening of memory. Insomnia and sleep, over-the-counter sleep medicines other than melatonin are often problematic. And so, the entire over-the-counter aisle in the pharmacy is just replete with basically rebranded Benadryl or doxylamine, which is the agent in NyQuil, and they're both anticholinergic drugs that can cause confusion and worsening of behavior in older adults. Antipsychotics, this is a good example of when we have to engage in some real risk-reward decision-making, because some antipsychotics are anticholinergic and can worsen behavior. Sometimes the benefit there outweighs the risk, but we use particular antipsychotics over others because some of them have more anticholinergic properties than the other ones do. Things for motion sickness, dizziness, nausea, vertigo is a very common problem. So dimenhydrinate or Dramamine, meclizine or Antivert are both anticholinergic drugs that can cause problems. This is sort of my list of worst offenders, and I ran this by one of my colleagues in geriatrics who had me add the two at the bottom, muscle relaxers and these stomach antispasmodic or anti-cramp agents. All of these, really can cause problems. And so these are things that I'm scanning the medication list for, to see if they're present and how long have they been there. Did somebody just add oxybutynine right before the behavior change happened? That's something that's really important for me to know. And there are other options for treating this symptoms, but I have to, we have to see how bad the symptom is, how much that medication is helping versus potentially harming. So it's always an individualized approach to this. A quick word about benzodiazepines and Ambien, common drugs, but can almost always a bad idea in dementia. It's associated with an increase in falls, worsening cognition, as well as pneumonia. There are exceptions to every rule. So I certainly have patients for whom I need to use these drugs, but it's always I'm always thinking very hard about, are we causing more harm than good here? And then this goes for everything, but but really especially for benzodiazepines, is even the drugs that are problematic, you can't stop right away. You got to do that under the direction of a healthcare provider, because, for instance, benzodiazepines, if people have been on them for a long time, suddenly stopping them is really like suddenly stopping alcohol. You can have withdrawal and seizures, and it can be quite severe or even deadly. This is just an example of the receptor that benzodiazepines bind to. So those little pink circles there represent benzodiazepines, but the green one is alcohol. And so it functions on the same receptor in part that alcohol does. So this is something that if people are on chronically, it can take a long time and a thoughtful, slow titration to get off. When I see somebody, my approach to treatment is first, safety, determine if we need to treat. Second, are there reversible causes that we need to be addressing? Third, are there even if treatment's needed, are there non-pharmacologic, non-medication options that I can reach into? Can we redirect, change an activity? And then finally, we get to medications. Sometimes it depends on the diagnosis. So Lewy body dementia in particular has some specific differences in how I might approach which medications. For instance, the things like Aricept or donepezil are very first line for me with Lewy body dementia, even for things like psychosis, versus frontotemporal dementia, where I do not use cholinesterase inhibitors like Aricept or donepezil, because there's been some association with worsening of behavior and confusion in frontotemporal dementia. Often, though, it's really management predicated on the symptom that we're dealing with. So I'm going to go through a couple of different types of medications and what we tend to use them for. Antidepressants, mostly SSRIs and these other types of antidepressants that work a little bit differently, things like venlafaxine or bupropion. These are things that we're gonna use for agitation, depression, anxiety, and apathy. But with apathy in particular, I tend to use these other types of antidepressants because they can be a little more stimulating. Antipsychotics, these are tough in dementia because there's a black box warning, and they do increase the risk of all-cause mortality, risk of cardiovascular events, heart attack, and stroke. At the same time, much of what I do is engage in long-term palliative care for these behavioral and neuropsychiatric symptoms, and sometimes that risk, which is there, is worth taking to try to improve someone's quality of life, keep them safe at home. And so we do use these. In Lewy body dementia in particular, patients can be sensitive to antipsychotics. And so we really tend to use mostly Seroquel or this newer antipsychotic called pimavanserin. Psychosis is the big thing that we're treating here, those hallucinations and delusions. Aggression can require this. The smaller arrow is here for agitation because it's kind of second line if agitation's not responding to those first line agents. And then anxiety, when it's really severe and not responding, can sometimes be necessary to use these medications. The key here is really the lowest dose possible and effective for the shortest amount of time necessary. Cholinesterase inhibitors, it's a class of medications that includes, the two most common ones are donepezil and rivastigmine. In Lewy body dementia, these are really very first line for me, and I avoid it in FTD. There's some indication that it may, along with an SSRI, these may help with depression. They're often my first line for apathy to try to get some improvement there if someone's not on one of these medications. And just to point out, this is, these medications are approved for cognitive enhancement, but oftentimes in practice, Dan always said that it was the things that you couldn't measure as well with a pencil and paper test that really seemed to be of more benefit with this class of medications. And that's been my experience in clinic as well. Trazodone and mirtazapine are commonly used. They're old antidepressants that nobody uses as an antidepressant primarily because they make people too sleepy. So they're good options for insomnia, especially insomnia if somebody has depression. Melatonin is a common over-the-counter drug. Tend to use it for insomnia and REM behavior disorder. And so REM behavior disorder is when people are acting out their dreams, running, kicking, punching, screaming, hitting in their sleep. And we use higher doses in that than we do in insomnia. We can go up to as high as 15 or even 18 milligrams for REM behavior disorder. Namenda or memantine, it's the only drug in its class. Really kind of mixed data on whether it does much in behavioral symptoms. There's some evidence that being on a dose of Namenda and even Aricept may reduce the amount of antipsychotic that's necessary, which is a good thing since antipsychotics are associated with an increase in mortality. Benzodiazepines, so the yellow here is really kind of intended to invoke a caution sign, right? These are things that are there. We may have to use them, but I really try hard not to because of all the problems. Insomnia, not so much. It's rare that somebody has such horrible insomnia that these are necessary in practice. I do have some patients with dementia, with Lewy bodies in particular, who just have such a disrupted sleep-wake cycle, often in addition to REM behavior disorder, that a nighttime Klonopin is really necessary. If I'm using a benzodiazepine, it's rare that I would use anything other than Klonopin because the other ones are too quick on and quick off. The Klonopin at least gives you a little more stable dosing. But again, I do try to avoid these. Stimulants, another thing, sort of in a caution sign. I do use these from time to time, mostly methylphenidate or Ritalin, which you may have heard, it's commonly used in attention deficit hyperactivity disorder. And then modafinil, it's misspelled there. It's modafinil or Provigil. And I use this as an adjunctive treatment for depression. So if somebody's on an SSRI, they tend to have a decreased activation, more apathy. Sometimes a very low dose of this with an SSRI can help with depression. And then for apathy that's severe. And then in Lewy body dementia, there can be this horrible daytime sleepiness that's just the fluctuations in the level of arousal can be so severe that stimulants are necessary to just keep someone up and able to engage in their day-to-day care and activities. the concern with these are increase in it can cause an increase in anxiety, and it can increase the risk of blood pressure going up. So you got to monitor that. Pat had asked me to specifically make sure that I addressed sexually inappropriate behavior. This is a tough topic to talk about, to bring up with a doctor, and it can be tough to treat. There's two types of behaviors that are considered in this class, and those are intimacy-seeking behaviors, even if they're inappropriate intimacy-seeking. And then there are these disinhibited behaviors. People may expose themselves, disrobe in a way that's quite disinhibited and inappropriate. Treatment's tough, especially in residential care facilities, because there's this need to balance ethically normal sexual desires in humans that don't go away just because someone has dementia, with the expectations of carers and family members for what is or isn't appropriate to happen. First, always try non-pharmacological things, redirect people, clothes that open in the back so that they can't disrobe, finding alternative activities to keep someone busy if they seem understimulated and that's why they engage in it. If we do use medications, I have to kind of figure out, well, what's driving it? Is it an obsessional thing? Is it a psychotically driven symptom? Is there confusion present? And based on that, this is an example of a type of flow chart that you might use with trying these medications, antipsychotics, SSRIs, or even things like Aricept. Anti-androgen therapies I've rarely, I can recall only a time or two where I've seen these have to be used. Generally do try to avoid that. There's some other medications, sometimes beta blockers like propranolol can help, and really have to regularly reassess for whether the treatment's effective. So when can we help? We meaning the medical profession. And quite simply, when the symptoms are disruptive and when you feel like you're needing help, that's when we are and should be there and available to help. When we start trying to help, it's important to monitor response. And this depends on the medication and the behavior. And it's important for us as physicians to really engage in a lot of good psychoeducation to make sure that you understand what we expect to see. If we give you a medicine that we don't expect to work for 4 weeks and you go home and it's not working after a week, you're going to be very disappointed. And we should tell you when we expect those things to improve, or give you a range. Set the expectation that this may take. Sometimes in depression, from the non-dementia trials, it can take up to 6 to 8 weeks to determine whether something is truly effective or not. And there's no gold, the gold standard for is this working really comes down to me asking you. So patients frequently will ask me, well, how will I know if it's working? Meaning, how will I know? And the answer is, you'll tell me. I may try to ask certain questions, but really you're going to be the one that knows, is this working? A couple of words about my thought of how to most effectively partner with clinicians, recognizing that some of this is just, it's unique to the clinician you're working with. It's unique to whatever relationship you have with your physician. When I'm taking care of somebody with dementia, I am taking care of the dyad, the patient and caregiver, because I can't just take care of the person living with dementia. That's not enough. It goes back to that, in the airplane, when they tell you about your oxygen mask, you got to put your own oxygen mask on first. You have to take care of yourself to be able to take care of the person you're caring for. Sleep here is huge. I see so many caregivers that come in who are just exhausted. They're not sleeping, they're worn out, they have no help. And this is challenging because our health system doesn't always do a great job of providing that additional help. Shared decision-making is really key. I don't prescribe a treatment without without the caregiver and the patient understanding what it is we're trying to do. And there are very few things that I have that if I offer it and provide the rationale, and on the other end of that conversation, someone says, no, I don't really want to do that right now, that's okay. The medicines that I'm giving are almost always symptomatic treatments. The goal is to improve the symptom and thereby your quality of life. And if we're not doing that, then I'm not going to continue the medication. So it's important. I always tell patients and families that I'm working with, just let me know if it's causing more problems than good, and we can safely get off of that medication. It's also important. Sometimes I have to tell people that's not going to respond well to treatment. I can't improve that thing, but you have to know that. I have to tell you that, or else you don't know what to expect. And then a key thing that I find myself telling my own family members sometimes is that, you gotta, this is a scientifically informed trial and error process. I know drugs that will help generally, but for an individual person, I don't know whether the thing that I'm choosing first because it has the best evidence is ultimately going to be the combination of treatment that leads to symptom resolution. And so it's important for me to set up this idea that, you can come back. You need to come back, because I need to know, is it working? And if it's not, we need to tack to a different course. For communication, the most effective way, at least for me and for most of the clinicians that I know, is if there's a health portal where you can send a message to me or your provider. That's going to be the best way. I can't use email to communicate with patients because it's not HIPAA protected. And so it's really most effective to use those portals. And I'm positive that some of you out there are going, yeah, I've tried that. Nobody's responding to me. And all I can say is I'm sorry. I wish that were not happening, because, I try to really keep into a good contact with patients so that I'm hearing from them, how are things going? And I try to set that expectation up front that, just send me a message and say, hey, it's working. And I'll send back a two-word message. That's great. And it lets me know that we're on the right path or not, and allows me to titrate how much we're doing with those medications. That's all I've got for you guys. So just special thanks to the Wake Forest Alzheimer's Disease Research Center and my current mentor, Dr. Kraft, where I'm talking to you all from today at the Wake Forest ADRC. And then here are just some pictures of my adorable children who are central to my life and my work. So happy to take any questions. I'm sure there are some in the chat box. Let me get to it.
Trey, it's Lisa.
Okay.
We do have some questions for you. We have had the questions flying while you were talking, so thank you so much for that. We will hang on one.
So I've got the questions up. What would be the best thing for me to do?
Let me just run through a few of those for you, okay?
Yep.
All right. Asks, going back to the start of your presentation, how do you measure executive function when you're evaluating a person for dementia?
So executive functions are a cognitive modality. So fundamentally, those are going to be measured on pencil and paper types of tests. The history is really important for getting a sense for whether there is executive dysfunction. But in the clinic at the bedside, I may do a short battery of tests to assess that. Or in our clinic, for every new patient evaluation, people get about a 2-hour neuropsychological assessment, and my neuropsychology colleagues are going to be assessing executive function for me to kind of give me a sense for, is that a problem or is that intact?
Okay, and if someone can't get into your clinic, especially because they don't live in the area, is there an easy way or a suggested way for them to find help in their own area?
Yeah, so there is, trying to think if there's a good, there's not, I don't know of a good registry that sort of has, here are your dementia specialists. In general, you know, any neurologist should be comfortable with more common forms of dementia. Some neurologists don't feel very comfortable with behavioral presentations, and so they're less confident and comfortable treating those symptoms. And it may be helpful to have, if there's a geriatric psychiatrist in the area or something like that. I don't have a great registry for, like, how do you find a doctor that does this in Wilmington or in Rocky Mount or in Asheville? There are, some of this is just kind of word of mouth, which is not the best way for it to be passed around.
Right. And so there was a question asked, what if a neurologist is not familiar with Lewy body dementia? It's not an uncommon dementia, but a lot of people have had trouble getting a diagnosis.
Yeah, it is. And somebody I just saw, Hellebrand in the chat just mentioned that people can check with the Alzheimer's Association for the state. Sometimes they have a good list of people who are accepting referrals for dementia. Lewy body dementia, in particular, especially dementia with Lewy bodies, because it presents with milder motor symptoms. I've run into a lot of, oh, this can't be Lewy body dementia, they don't have Parkinsonism. And that's just wrong. You can absolutely have dementia with Lewy bodies without motor symptoms. And so it's something that I'm trying to address on a daily basis in resident clinic here, where I'm doing teaching with residents, trying to help people learn these more common diseases better and the management strategies. The Lewy Body Disease Association has a lot of great information about Lewy body dementia that if you have a clinician who's open and accepting and willing to hear that information, would be great to give them. And I've found that some people are actually quite accepting of that, and they really want to help, but oftentimes in a busy clinical practice, it's hard for people to navigate those things they may not know as well. And I have the luxury of, I don't see all of neurology. I'm really a subspecialist and just see these types of presentations.
Okay, great. Can delusions go away on their own, or do we need medication?
They can sometimes go away. They can fluctuate. The delusions can be, you don't have to treat them if they're mild and not bothersome. And they can, go away on their own. But sometimes if they're really particularly severe, then it does require treatment. And to be clear, the treatment is not particularly, they're not always effective. And so it can still be a trial and error there.
Okay. Question about Lewy body specifically. Is there any pattern in the brain to where Lewy bodies emerge, or is it entirely random?
Yes, so there are patterns where Lewy body dementia emerges in the brain, depending on whether it starts as Parkinson's disease, where it sort of starts in the lower parts of the brain and then spreads upward to parts of the cortex or the covering, or whether it's dementia with Lewy bodies, where it starts in the more sort of higher cognitive functions of the brain and then progresses downward. That said, Lewy body dementia is not particularly, the atrophy patterns are not all the thing that really helped me on imaging. As much with Lewy body dementia. There's a special type of brain scan called a DAT scan, which is it's a type of a SPECT scan, which is a nuclear medicine test that measures the binding to something called the dopamine transporter in part of the brain, and you see an asymmetrical presentation of that in Lewy body dementia.
Okay, great. We have had a lot of questions about very specific types of medication. And I'm wondering, instead of asking all of those here, could you maybe go into our Q&A after this and type in some of those? We've had quite a few specific meds listed. Okay. We do have some resources being listed in our chat now by people who are on the webinar as well. So we want to thank everyone for that. Here's a question from Sharon. Her parents were automatically treated for dementia by their primary care doctor, not suggested to go to a specialist. Is there usually something that triggers that suggestion, or is it okay to be treated by the primary care doctor?
Yes, it is very common to be treated by a primary care doctor, and in many cases, it's normal and appropriate. And there may be times where I'm not going to provide much different actionable information, and with the number of cases of dementia in America each year, it's simply not possible to for everyone to see a subspecialist. There are now 475 behavioral neurologists and neuropsychiatrists that are board certified in the country. If we've got 6 million people plus with dementia, my clinic's going to be very, very, very full. And so part of what we try to do is to help support primary care doctors, working in, giving them resources to help when necessary. That was something Dan was quite passionate about, is how do we help primary care providers do better with the resources that they have. And so, I would say that if the PCP feels uncertain about the diagnosis, or if somebody wants a second opinion, that's when you might seek a referral to a specialist. It doesn't have to be somebody who does nothing but dementia care. It may just be seeing a neurologist or a psychiatrist who specializes in dementia to get that second opinion.
Okay, great.
And I'm going to go through the answers and answer all of them that I can. So anybody who's not gotten their question answered, I promise you, I am going to put in answers here.
Yeah, we have almost 300 people on our call today, so we can't answer all the questions right now, but we'll get to them as quickly as we can. So we've had a couple of questions about someone with mild cognitive impairment. And one of those questions was, even if someone is really able to still do a lot, is donepezil or a medication similar to that still good for someone with MCI?
So there's no data that it helps. The trials have looked at this, and placebo-controlled trials, there really did not seem to be a difference in MCI compared to placebo. Now, that being said, there are some instances around Lewy body dementia where I will sometimes choose to go ahead and start a cholinesterase inhibitor. And when somebody comes to see me, I'm going to tell them what the data shows, but I'm not going to say that we have to stop this or things like that.
Okay. And can you speak a little bit more about contraindications for medications with Lewy body disease in particular?
Yeah. So the big ones there are antipsychotics. There's a sensitivity to those. And so, for instance, risperidone, common antipsychotic, actually, if you look at Alzheimer's disease, it probably has the best data for helping to control neuropsychiatric or behavioral symptoms. But it's not one that I'll use if I think the diagnosis is Lewy body dementia, because patients with that tend to be more sensitive to to risperidone and antipsychotics more like that. And so I will, steer towards quetiapine and the like. In general, dementia with Lewy bodies is, there's a sensitivity to anticholinergic medications or anything that prompts a delirium. So things that there's in the research world, there's this whole research criteria for prodromal dementia with Lewy bodies, where we're trying to really find this early on, and sort of unexplained, easily triggered, prolonged delirium is one of the things that may herald that. And so my general impression is that in DLB, medications are just, people are more sensitive to them. So whereas somebody may tolerate a low dose of a medication for bladder problems, in DLB they can't. If somebody may tolerate a low dose of Paxil, DLB they may not, because of the anticholinergic properties.
Okay. All right. We have a few questions about is autopsy still the definitive way to get a diagnosis, and is that for every type of dementia?
Yes. So the only way to get a definitive diagnosis is autopsy. It's can be difficult. It can be quite difficult to get an autopsy. We're able to do it here at Wake because of the ADRC and our brain bank. Duke, if you've been a patient at Duke, you can get an autopsy done there because they have a brain bank. Otherwise, it's going to be self-pay, private pay. And so most folks do not get an autopsy diagnosis. Biomarkers are improving and they're coming further. You can, in some cases, I will get Alzheimer's disease biomarkers, but it requires a lumbar puncture to get done. And there can be reasons to do it, but there can also be reasons not to pursue biomarkers. And in most cases, I don't have everyone get a lumbar puncture because it won't help us change the management. It won't provide a tangible benefit unless somebody just absolutely wants to know with the highest degree of certainty which type of underlying neurodegenerative dementia that they have.
Okay, great. Well, I think we're going to go ahead and end there.